All right, if you're joining us on the audio and video from our Titus County website, we are just barely getting started here. We were running a little late getting a disc in our camera. We are on item number 1, accepting public comments. And I have a second public comment. Judy Kent, if you'll take the podium, please.
I would rather wait. I just did that just in case I want to speak on the real estate.
Okay, sure. Yeah, that'd be fine. All right, we'll hold off yours until till item number 4. All right, is there any other comments at this time? Yes, ma'am. Sure. Okay. That doesn't start till 10. 10. I piled a few more items on top of what was going to be just be an insurance update workshop, which was always scheduled at 10, and I gave the commissioners the option of doing some other housekeeping before or after, and so we started at 9. But CAPS should be here at 10 o'clock, and you're welcome to come back at that time. All right, anyone else? And of course, as always, you may speak on any agenda item. We do ask that you would fill out a public participation form prior to the beginning of the meeting, but you may speak either at the beginning or on any particular agenda item. Item number 2, consider and possibly approve the appointment of Dr. Chris Burling as Titus County Health Officer. I'm sad to report that after many years of service to the county as our county health officer, Dr. Reichert has retired from his practice. He is dealing with some health problems and is unable to continue in that capacity. And so I have been trying to find us a replacement, and my friend and personal physician, Dr. Chris Burling, has graciously agreed to take this responsibility on. I gave him some material to read over to make sure he knew what he was signing up for, and he says, I would love to serve the county. So with your approval, we will appoint Dr. Burling, and if not, I'll take other suggestions from you.
So moved.
Motion by Commissioner Hockaday and a second by Commissioner Fields to approve the appointment of Dr. Burling as Titus County Health Officer. All in favor, say aye. Aye. Opposed? And again, the county health officer doesn't come into play a whole lot in the event of a countywide emergency. He would be our go-to person for medical expertise to help us coordinate in the event that we had an outbreak of a disease, or we had problems related to water supply or something where we needed guidance from a medical professional. That would be Dr. Burling's main responsibility. Item number 3, I would like to request an executive session pursuant to Texas Government Code Section 551.072 for deliberation regarding real estate property and possible action in open session thereafter, and so I've put item 4 immediately after that. So at this time, I'm going to ask that we go into executive session, give us a few minutes to discuss this, and y'all are welcome to hang around. I don't expect this to last a whole long time, but nonetheless, we'll come find you out in the hall or downstairs when we get finished. Oh, you might as well.
We leave your recorder on? Leave your recorder on.
Okay, now we're going to have a separate
You do another one for the workshop.
Sorry, I didn't mean to put you on the spot.
Okay.
Can Sheriff sit in on
Any elected official you want to sit in here, you just have.
How are you doing?
As far as I know.
I mean, did you have wind?
Oh, wind.
Tornadoes?
Yeah, I'm on
Yeah, we had some roads where they couldn't even get out of their houses. I didn't know anything about that. Well, did you win?
I'll ask if any of them want to make a motion. right, it is 10 o'clock. Go ahead.
Electronics are slow. Okay.
All right, it's now 10 o'clock, and we are back in regular session. We've completed the executive session. I don't believe there's going to be any action come out, but I don't want to keep you all from making any motions. Anybody have anything to do? All right. I do still have a request from Judy Kent to speak on item number 4. Judy, no action is going to come from the court. Anything you'd like to say? Okay. All right. Well, it's 10 o'clock. We're ready for a health insurance workshop. Is there anybody from CAPS out there? Okay. Very good.
This is the summary of the insurance we got.
Let me say one more thing. The items that we discussed in executive session are to stay in executive session, and they are not for public discussion at this time. Call Dr. Burling.
No, she can't if you want her to. She really wants to stay.
Thank you.
Hello, how are you?
Chris, do you pronounce your name Kaplinger or Kaplinger?
Kaplinger.
Kaplinger, okay.
That's all my husband taught me to say.
Well, I'll follow his instruction. All right, well, we are down to item number 5, and that's our health insurance workshop. And let me introduce our guests today. We have back with us Tony Melton from CAPS Insurance, Chris Kaplinger from UMR, and who's the new face there on the front row there? I didn't recognize you from the last time. What have you changed your hairdo or something? All right, I like it. I like it. I thought you were a younger sister or something, maybe.
You second that,
I am, yeah. Is that not allowed? Tony, I'm going to turn it over to you before I get in trouble, all right?
Okay, I sort of say, Chris is just here to basically, we tried to do this about a month ago, and I think everybody was looking at the wrong month, so she tries to come back after the plan year has finished, which was the plan year of 2013, just to sort of basically go over how the plan ran, which we all know we've had a really good year. But just to give you just a pretty high-level overview of last year, then if y'all want to discuss anything going forward, any issues or anything that we need to be aware of, then, we will definitely talk about whatever you all want to talk about from that point forward. So,
Can we move that mic a little more in the center, just to, maybe, in fact, maybe between you and Chris would be great. Thank you.
Okay. So I'll let Chris everyone should have gotten a bound copy of what she's going to discuss, and we do have one extra. If you want. Sure. Here, y'all can share that. Okay. I was, but he got it. Okay. You missed your chance. You did. Okay. Okay. So Chris, if you kind of want to talk about what you think are the high points of the plan and anything that we need to address as far as problems that we may have.
Okay. Well, first of all, this is a plan overview report for Titus County, but I also want you to know that there's comparative data in there based on UMR's entire book of business. So where you see the column that says UMR data, that is taking and comparing your account to our entire book of business, which are normal, and on the front, on the front page of this report, on the bottom it says the normative data. We're comparing it to all of UMR customers, excluding any retirees, and our average customer size is 1,370. Well, we have groups, 1,374 groups at this time, covering a little over 900,000 employees and almost 2 million members. And actually, this has been updated since then. That UMR currently has 2.6 members within our book of business. Our prescription information, again, is also comparative to all of the customers that use the Optum RX, which is our own pharmacy. And then the data is comparative to 12 months of incurred claims, meaning that they incurred during the time period of October 1st of 2012 through September 30th of 2013, but were paid within the 12-month time period of last year, January through the end of December. So if you turn to the second page, this is just giving you a recap of what your group looks like as a demographic overview. You can see your average employee age is about 45, very comparable to our UMR book of business. However, your average member age is slightly higher, to being 40.06 years old. And then it breaks that down even further in the next table of the average employees by age and gender, and then the next table down below is the average members. And then if you'll come down to the bottom, you can see how your coverage tier is, meaning how many employees do you have. Subscriber only is employee only. And then you have how many employees plus spouse, employee plus children, and then employee family. Our next page talks about your claims overview. And in the first table, it'll show you how many claims were billed for Titus County in 2013. We had a little over 1.2 million. Ineligible claims are claims that are not covered by the plan or not allowed. They're not charges that would be considered under the plan's benefit. So there were 134,000 claims that were ineligible.
That had nothing to do with deductible. That just means
right.
It was a procedure or whatever that
Right.
wasn't covered under any circumstance.
Exactly. Or a benefit that was billed that is not allowed under the plan's benefit at all. Yep. And then the price savings, you can see that of 1,092,000 claims, almost 50% of those claims were actually discounted through the UMR, UHC, or United Healthcare Network. So we discounted the claims by $551,000, leaving the medical total to be allowed at $540,000. Benefit design is where your deductibles and copays come into play. So 104,000 of that was member expenses. Then you have coordination of benefits where someone actually had other insurance, which was primary versus Titus County's benefits. So you had a spouse or an employee, a spouse or a dependent who had other insurance that should have been primary, then Titus County paid secondary. Leaving the medical paid for 2013, $432,000 in medical claims. We had $195,000 in pharmacy claims for a total paid claims of $627,000 last year.
That's your question. That ain't, the $1,227,000 total bill is all claims.
All claims.
Even if it was somebody that was $300,000.
Yes, all the claims. Yep, total bill, before anything else was considered. In payment metrics, I just wanted to point out that in looking at it on a per employee per month basis, for 2013, under medical, your payments added up to about, on an average of $291 per employee, which is well below the UMR norm, almost 52% below the UMR data. So that is really, really well. As Tony stated in the beginning, you had a very good year last year. Plus your discount average went up from, I think it was previous to that, around 35–40%. You gained anywhere from, you gained almost 10% more in discounts. So that does help your plan a lot.
How do you explain that? I mean, that's so far different from the norm.
Well,
I can tell you, we had 5 major claims last year of the year before. That's the reason
Right.
it's down.
right.
And that you got to have these good years with the bad years.
Yeah, exactly. Yep, and in our industry, they tend to happen like in a 3-year cycle. You get really good, and then it starts to unfortunately go bad. And so hopefully, we're going to have many more years to come where it's
Yes.
good.
Some of that then first year, too.
Yeah, and some of this is the first year. Health First was paying your run-out claims for the first 6 months, so there's some claims data from their history, but you didn't have any shock claims at all this year, meaning you didn't have any stop-loss hits, so no one went over the specific level, so that's a really good thing. And then our discounts come into play, and to answer your question, Judge, about being so far below the norm, a lot of it has to come into plan design. Your plan design versus what our other customers are, it could be, I would say your plan design is actually a middle-of-the-road plan design. It's not too rich, but it's not too far to where the employees pay a lot of expenses out of their pocket. But I'm having customers with healthcare reform, with financials, that are actually taking their plan and moving it to the right a lot, where the employees are having to pay a lot more money. And you're on your pharmacy, in the pharmacy under the members. Now, here's where you're a little higher in the UMR norm of almost 38% in the average prescriptions that are paid out. Any other questions on your claims review?
Any idea why are prescription claims skewed so much higher than that?
This report, unfortunately, doesn't give you a lot of data on the claim side. I can go back and ask for a general report and kind of look at your average prescriptions. If I were guessing, and again, I can go pull some data, it's probably more of your brand prescriptions are being filled versus your generics. That should actually be changing. We want to get people to do more generics because a lot of drugs came off of patent in 2012 and 2013 to where generics are available. However, that also contradicts what you think when that happens, that everything becomes cheaper. For about the first year and a half, it means that all the manufacturers can now make that prescription, and then they all make it and set a threshold up here. And as it becomes less popular, then the prices start dropping. I'm hoping that that will be the case for 2014, but I will pull a report and look at your top prescriptions.
And this is the actual cost of the drugs, correct? Not what the people are paying.
Right, yes, this is your actual cost of your prescription to what the plan paid, not what your employees did.
Right.
I know, Judge, we, in the years past, and I'm not talking about any individual, I'm just talking in general terms, but I do know we have a high rate of diabetes as far as our county employees are in. And where you have consistently have to take your medication and stuff, that would also be a factor in there.
That could be. And I will pull your pharmacy data and look at your top drugs, and we can identify, what those prescriptions are used for, and that may be the case.
Do we have the ability to zero in and find out who is continuing to buy brand names when there are generic alternatives? And can we specifically sit them down and talk to them and say, not only are you costing yourselves this much, you're costing the county this much on those drugs when you buy them? We would sure like to see you consider.
We didn't put this therapy in place. It's sitting down an individual and speaking to them. You are self-insured, so you do have the ability to have that PHI information. Those who are designated have the ability to have PHI.
What is PHI?
Personal health information. It's your privacy of your personal health information. So if you were to sit down to talk to a member who was using a brand prescription, you may be able to identify what that prescription is used for. It could be for diabetes, or it could be for a heart condition. We can do member communications, where you could, if you have a newsletter, we could do payroll stuffers. We have flyers that we can provide that can talk to the effect of using generics over brand and how the cost setting can be.
That's an overall thing.
I think you need to do that as a group, not as an individual, though.
We can do it as a group. Like I said, as an individual member, those that are authorized for PHI, they can get it. And I would,
Most of the time, a group will do it overall, where it's a payroll stuffer and not a target to any one particular person. But what I was asking, Chris, is that there is something called step therapy. I think we did discuss it last year, but that's where you actually have to go and try a generic first before the brand you work up to it, which is something y'all didn't want to do.
right. And it's interesting, I was in Houston Tuesday and Wednesday, and in their news was talk about Nexium. Everyone, and I am not a person who takes prescriptions, but I've always heard for years that purple pill is the best out there. They actually interviewed several doctors and showed the average cost of that purple pill was $281 a pill versus using some of the over-the-counter medicines and some of those generic versions of the purple pill that are available, and how the cost savings. And they were saying that the what's the word they use? Efficacy, meaning the effect of that drug. The over-the-counter and the generics now are at the level of the Nexium pill that people really shouldn't have to need to use the purple pill anymore.
But we're all subject to advertising and marketing, and I think some doctors will say, hey, if you want that, I'll give it to you. So there may be some education there in that we can work with the group as overall and to say, hey, if you're taking something, and maybe have a list of those drugs that are the more expensive drugs. If you're taking one of these drugs, you might be aware that you could buy it for this amount and have that comparison. Right.
Well, the mindset is, I'm going to compare this drug versus this drug. Oh, well, it's only costing me $25 more. Well, you may be looking at the tip of the iceberg. It may be costing the county $200 more. And if somebody showed me on paper, Brian, here's what it's costing you, but Brian, here's what you're costing the county by taking that pill when there's a suitable alternative, I might look at that and go, wow.
If you remember, I showed you something during last year called Compass, which was a separate company that actually evaluated not only your medical claims, but also your drugs. I think, you didn't decide to do that, but I think working through UMR, we can come up with a similar chart where we're saying maybe Crestor is another very, very expensive drug, right? Nexium, those pills that are definitely on the higher end of the cost, but yet somebody might be paying, $50 for it, and they're thinking, oh, it's only $50, but it could be $300 or $400 or $500 a month to get that filled. And just to compare it and say, hey, have you tried this? At least maybe try it. Some people can't take the generic.
Well, who is the person to have that discussion with a particular employee?
General rules,
No, I'm saying, no, I'm saying have a flyer.
But is there not a way to have some one-on-one counseling, even, I mean, a phone call from UMR to a particular employee?
We do have education and information that we could reach out to members and give them educational materials that say, you know, there's a generic available. I could look into seeing what we could do as mailers to the members, identify all members who are taking brands where there's a generic equivalent and do a mailer to them. So it's not, you know, specifically sitting down and talking to them. They may not know that conversation with their doctor. They may not know that they have that generic available and it is cheaper to the plan. There is a gentleman who's assigned to your plan by the name of Albert under the pharmacy, and I can take this back to him and work with him and come up with information, share it with you, and if you approve it, we could do some mail outs.
You really run the risk, though, of singling out some particular person and having a one-on-one set down. That's just, you probably just don't want to go there.
I'm not in favor of doing that at all.
And I wouldn't be either, but you can talk to the group as a whole, and a lot of people may not understand or realize that what the judge is talking about, that pill is very expensive because it's
Right.
brand name, but we still, to me, I think we got to be very careful with the Privacy Act.
Yeah.
And when we're dealing with people and talk to everybody as a whole and not single out anybody.
What I'm
any one
thinking is
person.
that maybe saying
And-
the credit store and maybe the national average cost is, and I'm thinking this is correct, it's around $400 a month. You know, as a whatever category or tier that's falling under the plan, say you're paying this, but did you know that you could have maybe these three options that would be $5? And have that for maybe maybe 4 or 5 different classes of drugs. You know, having wherever is popping up as the highest utilizer, but we could customize that to be sent to everybody, not just those particular people that are overutilizing. That's what I think.
And I'm saying this because I'm really blessed, but I don't take any medicine. And that's a blessing because a lot of people out there do. My wife, and I can use her because she's my wife, she took Imitrex for migraines. Didn't have to have them, but every now and then. Well, they come up with a generic brand, and it doesn't work near as good as that original brand.
And that's what I'm saying. Some people have tried the generic, it's not working, so they've gone back to a brand.
But I think that
that's-
should be considered if that's what it takes.
Right.
Because if there's any possibility, we take the generic brand.
Right. And I think there's a lot of people.
And we do have educational materials that we'd be willing to send out to your members. And we can share the flyers where they can be posted in the different areas, the different departments. We'll come up with,
Okay.
we'll
Well,
look at your drugs and then we'll come up with proposals and bring them to you and let you decide.
Well, I agree with Thomas. I'd rather have a group. I don't want individuals to be singled out.
Not a problem.
Any other questions before we move that page?
Your next page 4 indicates cost by the claim category. So your categories are your inpatient, your outpatient, your physician, and then ancillary. Again, your inpatient dollars paid was very low. That speaks to having a very good year this year. Majority of your folks were able to go outpatient, which is a very good thing because it's a cost-saving measure. And then your physician charges. Now, these do encompass inpatient physician charges and outpatient and also just office visits. Ancillary includes any durable medical equipment, some prescriptions that are paid under the medical plan, where there are some, and then any prosthetics, which those dollars were very low. And then your pharmacy, again, your pharmacy paid dollars is low. Any questions on the categories?
I could definitely see a big improvement on the pharmacy and their prices.
Well, there you go. Just look at that norm. Look at the norm compared to us. You know, we're double the norm on our prescriptions. Something's wrong here.
Well, and your plans, co-pays, you have a,
Steering it to generic.
you are doing a good job in steering it to generic.
What is it,
by-
0 and 50 or?
It's $5 for generic, and then you actually bump up to $25 for a brand non-preferred. So there is a big spread. But there are some people that just believe that brand drugs work best for them and may not ever have considered using the generics or having that conversation. You know, pharmacies pay, they're always in the mail, they're advertising on TV. They caught on in the early 90s that was the wave of how to get people to specifically go to their doctors and ask for a certain drug. And then the other thing is they hear the symptoms and they believe they fall under those categories. Unfortunately, I got several family members that are exactly like that.
And you can find a doctor that will give you a prescription if you try hard enough.
Right.
Yeah, it doesn't matter to them. They don't care. They're just
You know,
writing out a piece of paper.
My pediatrician did the same thing to me with my little one, and I questioned him and said, why would you prescribe a prescription that is a brand when there's generics available? And he said that most of his patients will tell him, or the parent will tell him, I want that, and if I don't give that to them, then they'll go down the street to another office. And I said, but you never had that conversation with me. You never asked me. You just wrote me the prescription. Education of telling you people that they can ask those questions to their doctors is I think gone by the wayside. You know, I'm in the business, so I question everything my doctors tell. But for the most part, people don't. And it's not berating the physicians, but it's engaging in knowing what they need and knowing what costs are.
Do we have automatic generic substitution so that it has to be written?
Yes.
Dispense is written.
We do have on your plan where if they don't indicate that it has to be dispensed as written, a generic is automatically filled.
So that means you got doctors writing the exact prescription and saying, do not stray from this brand.
And if they do that, then it overrides our plan.
Right.
Correct.
Right.
Okay.
I think the deal there is that you probably don't have enough people to put me when I go to the doctor. I don't go very often. I don't remember ever telling Dr. Mayweather that whatever prescription you're writing, there, I've never told him that.
If you'll notice that your prescription at the bottom of it, doesn't matter what it is, there's two sides. One says dispense is written, and what does the other say? Substitute for generic when available, and they check one or the other. So if you look at your prescription, it's on there.
But sometimes they'll ask, sometimes they won't.
Right.
He'll say, what do you want me to call again?
Yeah. But he doesn't ask you what is called in.
I never looked.
Will you
No.
change that now, going forward?
I'll try to remember when I go to the.
I know CVS used to put on their, when they stapled the receipt on the outside, they used to say, it cost you this much, and then they would highlight what the drug actually cost. People didn't believe it, so they quit doing it. But that was, I thought, insightful, that this prescription actually cost $200, but you pay $5.
Because,
But I think the point is, most of these transactions are taking place at the doctor's.
right.
Yes.
The patient
Exactly.
Yes.
Yeah.
And the doctor will probably write whatever they tell them to
Right.
write, but if the patient doesn't think about telling them, now, I need you to make sure that's the generic.
Which goes back to that education, which, I mean, I think a lot of this is just,
Which also comes back to, they're not going to care if it's not affecting the public.
Correct.
Obviously, we haven't gotten
their attention.
the brand.
Well, if we just got a lot of employees taking lots of medicine, that's one thing. If we've got some employees that can sit, if we've got a high payout on a narrow band of brand name drugs, maybe 3 different drugs, maybe we can do some education and say, listen, guys, continued use of these name brands when there is a perfectly suitable alternative will prevent us from being able to provide as rich of a plan. Until it hits them in the pocketbook, they're not going to make that change, not for $25 difference.
Right. And let me take this back and come up with some ideas and ways, and that'll be our focus for 2014, is not only on the medical side, but let's really work and focus on your pharmacy piece. So that hopefully next year when I'm reviewing the 2014 data with you, we've seen some decreases in your pharmacy costs.
Good. Okay.
Thank you. Our next page shows your key indicators of your, again, your metrics. This actually goes a little further down than the prior page, so it looks at your emergency room visits, your office visits per 1,000, lab services, and radiology services. You're well below our normative on emergency, office, and lab. Your radiology services are much higher. And I could not find, and actually when you look at your top service categories, that's your number $1 that was spent last year is radiology services. So it's your MRIs and CAT scans and your x-rays. That's where those items fall. And not having a lot of large claims, your emergency room service visits were so low. So I'm looking into this further because I'd like to see what this was and see if there was something that indicated that. But at this time, I don't have an answer for why that was so high. I don't know if, MRIs and CAT scans are being abused. I don't think so, because you do have an authorization of medical necessity around those. So it's not like you're going to run out and get those all the time. Those are highly reviewed by UMR. Right, exactly. Now, as an employee, you can't just go and request one. They have to be ordered by a doctor. You have your special services and treatments. These are your anesthesias, the supplies used during surgery. So this actually ties to your radiology. So if you're having MRIs and CAT scans, you generally either sometimes have to be put under because you can't handle the little thing they roll you into. I'm trying to think of it, all I can see is the MRI room they roll you into, or you needed a dye injected to be able to do that service. So that's what those other services treatments go into. And then other services is where you have your diagnostic screenings, non-hospital injectables, medications, and those can relate more to a diabetic person who is getting some services under the medical side that require, injectables that are paid under the medical plan. So there's more research.
What is
coming.
PMPY?
Per employee per month.
Per employee
Or
per...
per member per month. Sorry.
Actually,
per member.
PY is per year.
So on an average, your per member per year cost under radiology was $606, where our normative is $307.
Okay.
So this is a category I'm looking into further for you. Inpatient summary. Good news here is that you had very few admissions per 1,000. Your admit days were only 52, where our norm is 269. Your average length of stay was about 3 days. And then your allowed amount per admit day was on average about $4,600. You only had 3 admits all year last year. And after all the discounts and deductibles and co-insurance were taken out, across the plan, $39,285. These are really good numbers.
That's amazing.
Yeah, it is. It really is. Our next page is page 7, which is on network utilization. And so you had no out-of-network for your inpatient or your ancillary services. We do have a few dollars that were out-of-network for outpatient and a few dollars that were out-of-network for physician. And I think this is, under the physician side, correlates to when we, in the beginning of the year, we had those lab services that the doctor was ordering and the patients were going to the hospital and they were falling out of the network. So that's why you'll see those dollars. Those should, your members are doing a great job of staying in network. I do believe they see the value of staying in network for the discounts and them paying a lot less money. Your deductibles are lower, your discounts are higher. So, but I believe that $6,300 correlates to that. We made that plan change 4/1, not April 1st is when we caught it and changed it. So then from there, it's working very well.
I think the big thing is convincing the doctors that they could do it in-house.
Right.
And I heard Tony tell point blank that it's part of the plan and we will pay for it.
Right.
And the doctor said, no, they won't.
Yes, it will. And our network folks made several calls.
And she tried her best to convince them, and finally, Dr. Williams said, okay, I'll do it, but if they don't pay it,
Right.
you're gonna pay it. I said, I'll
I mean,
pay
he
it.
still sends it across the road.
Dr. Williams?
Yes, sir.
What do you think?
Yeah, sure does, because I just had 2 done in the last month, and he sends both of them across the road.
Really? Because his claims, I mean, Tony, I know, spoke to his office, and then Network, our United Healthcare Network folks called and spoke to 2 or 3 doctors. I think Meriwether was one of them. Who was it? Wiring, I think, and then Williams. And they explained that under the benefits that you have and the
These were your
contract
guys,
agreement.
Thomas? Your men, your guys? Is it, or is this you?
With me, just last week, sometime, week before last, and they sent it across the road.
Just for general lab work?
Yes. I've had 2 in the last month, or 6 weeks or so.
You need to, maybe
Had a
there's some
low
personnel
blood
change,
count, and that's
we
what he
have
was,
another call.
huh?
I said, maybe he's had a personnel change and we have to have another call with him.
And maybe that needs to be another member information in a, you know.
Well, there's certain tests that he can't do in-house.
There are some
maybe
he might
that's-
not be able to do, but if it's just generally drawing the blood and then having those tests run, he was supposed to be doing that in-house and not charging that to go across the street. We can check on it. We do have-
I know that when they drew it, they said that we'd have to take it across the street because we can't do it in-house.
And that
And they
may
were
be
checking
charge
our
service
iron
he
levels,
put
what
in.
they're checking, so, it looks to me like that wouldn't be a,
Well, but the blood was drawn at his office?
do what now?
Was the blood drawn at his office?
Right.
Okay, so him drawing the blood was the right thing to do. Maybe those particular tests, whatever they were that he was wanting to do on you, had to go over there because he wasn't able to read it or run it. That may be the case.
I didn't think that was it, but that could be possible.
Okay. So on average, in the network discount column, you'll see that for an average on the inpatient, you received about a 52.42% discount. You had 51% discount on your outpatient charges. Your physician charges was slightly lower. Again, some of this contributes to the dollars that were out of network.
What
but it was
page we
still-
on? I done got lost during all that discussion.
I'm sorry.
Still on
page
7? Okay,
And then I'm in the second box, this
Okay.
is network discounts.
okay.
Your physician discounts was 49.1%, and your ancillary discounts were 49.8%, for an overall discount average on your plan of 50.52%. And we do have what we call secondary or silent networks, that if for some reason that provider or that facility you go to is not in network, then we have these secondary networks, which are down below on the discount by network. So we have some charges, $109,000 worth of charges that were paid by multi-plan. $28,000 charges were paid by First Health. And then your other network was TC3, which was about $2,300. So you still achieved some network discounts there, not as great, except for First Health, but the dollars were much smaller. To show your overall network discount of 51.7%, there was still $11,000 worth of claims that were paid out of network where there was no discount achieved. No, and to Tony's point of having some information that we could share with members on staying in network for your lab and x-rays, we do have a flyer that we can send out and hand out for employees. It can be posted in the break rooms or wherever.
But again, I think that probably needs to be customized to this group, because if you just tell people, hey, stay in network, a lot of people don't know what in the network is, in and out is. So maybe we can identify some of the providers or hospitals that people are utilizing. In some situations, I know that that's where they have to go. It's a situation where that's the only care that they can get for their particular problem. But at least just making people aware that if you do choose to go to X, Y, and Z, just FYI, that's completely out of network. What do y'all think about that, or would you want to do that?
Yeah, no problem with that. It looks like they're staying pretty close to the network.
You are, but there are some holes. I mean, and there's holes in everyone's network. I mean, but just basically reminding people once a year, and we might, could even do this during open enrollment. But I think maybe doing it maybe midsummer just kind of refreshes that and makes people a little bit aware of it, because people do forget, People don't do insurance like we do, and
Right.
think
So,
about that.
yeah, we can definitely come up with some things to send out throughout the year to remind them. We got engagement programs that we can offer. Any questions on your network utilizations and discounts?
Are y'all working, not to deal with your question, but are y'all working with these different hospitals or different doctors or something that's not in network to try and get them in there?
We're always asking and accepting referrals for doctors. An employee can refer the doctor can contact us. UMR's and United Healthcare Network is always looking to contract with physicians. They're interested, we will have a conversation. Some of the focuses that are working further on is on the hospital side this year in contracting those ER doctors. That's one of the big pushes this year, because those doctors groups tend not to be in network. So if your members are going to the emergency room and they're going to the in-network hospital, that doctor they see may not be contracted and in network. So there's some leakage there. The other part is that the ancillary of the anesthesiologists, radiologists, and pathologists associated with an outpatient or inpatient charge, we're concentrating on trying to get them contracted. Because again, they're a specialty service where in all these years they felt like they didn't have to be contracted because they knew that, in-network hospitals and doctors, as far as a physician referring them to that in-network hospital, you have a captive audience. They had to be seen by that ER doctor. So we're trying to say, well, you're correct, they're a captive audience, but we need you to partner with us.
And I have two questions. On those emergency groups, I've kind of heard that they're larger companies that have contracts in multi-hospitals. So if they're able to get the contract with a couple of the larger emergency room groups, that might, they're not actually going to Titus Regional and contracting with that. They may be owned by something
Right.
much larger.
Right.
That's a nationwide ER. The other thing too is very few people know whether their anesthesiologist is in network or not.
Right.
The few times I have been put under, I don't know if you know who your anesthesiologist is. They're just somebody who pops up right before you go under. So you don't have a
It's
whole
the
lot of
doctor's
choice.
preference.
Yeah. So,
But we are looking to talk to those provider groups. As Tony indicated, the emergency room doctors, they used to be more independent. Well, now they're coming together and becoming groups and contracts, and they're being bought up by the bigger ER doctor facility groups, so that they may own the ER doctor groups at Titus and also at Hopkins, and then down in Tyler and Longview. I'll brag a little bit that UMR has a lot of the hospitals within the state of Texas as our clients. I personally have several in East Texas. And we are working and partnering and leveraging you as a customer and you as our in-network hospital to get your ER doctors to come on board. So that's an angle that we're using to get those ER doctors and those anesthesiologist groups in network with us.
Have y'all been able to talk to East Texas Medical down in Tyler to get them to?
We've been in negotiations with them for probably 3 or 4 years.
I just wanted to ask.
Or longer. They want an exclusive contract, meaning that they want United to contract and use only them and not Mother Francis. And United will never do an exclusive contract. I say never. Most times when they go to a area where there's multiple facilities, they will not ever agree to being exclusive to one facility over the other. And that's why there's no agreement that can be made.
and it's not just United Healthcare and UMR. There's
Right.
other carriers who are in the same boat with East Texas Medical, and the big one in Tyler.
We still can use Pittsburgh.
But we
Yeah,
still use
we still have
Pittsburgh,
all the
Silver
outliers.
Springs,
Ones are good.
Yep,
just not the big ones.
just not Tyler, East Texas,
You
yep.
can't go to Tyler, but you can go to Pittsburgh.
Yes, you can. Yep,
That doesn't make sense.
I know. But they all saw the value of saying, we're far enough away from Tyler that we want to be in your network because we want the patients to come to us instead of driving down there. And so it's helped them establish a better base of people coming to their membership or people using their facilities.
I'll tell you one thing, they're full over there. I went over to visit somebody the other day, and the lobby, you couldn't even hardly walk. It's been
Really?
people in that thing.
Wow. So it's benefited them.
It's benefiting somebody.
Yep. The next page is page 8, which is claim distribution by patient. And the first thing I'll look at, the first table is 2012. You weren't with us then, so you can just disregard that. But 2013, you had, and I immediately always go to the bottom where the highest dollars are. You had one member that had claims within the $100,000 to $200,000 range. Again, this is the paid amount.
Not the paid amount, no.
Well, it says paid amount per patient. But this is not just inpatient dollars. So this is accumulation of one person incurred a little over $100,000 in claims, but it could have been with physician claims, outpatient claims, inpatient claims.
But they still didn't hit the spec.
No, they didn't hit the spec.
And prescription would be in that too.
This was a specific attached use at that point, was that ever specific?
No one hit the specific amount.
And what is the specific?
$50,000.
Didn't pay $100,000 on
No. That's where this, there were 478 services and 75 claims, and it was on one patient, but this says paid amount, but I believe that this amount is before discounts, because no one, I looked last night, I told Tony I was checking this, no one in 2013 went over your specific amount, which that specific deductible is set at $50,000, and no one is over it for this year either.
We even went back and asked Health First.
But that 627 number is the same number as on page 3, which is after the discount.
I know. But Carl, there was no one, and we even got your runout history from First Health to add up all the claims on the members who had gotten to at 50% level. No one went over your $50,000 in your specific. And we looked at all the claims. So I think that this title, even though it shows someone had $100,000 worth of claims.
Well, that'll help our specific claim premium, I guess,
Yes.
next year.
Yep, that's why your renewal for Sun Life was, at what it was, because there was no one that hit it.
Sorry, so, so.
Tony asked the question, is prescriptions also included in your specific, and I believe that is the
Yeah,
case.
that's all, based on the page 3.
Yeah. So it could be, that's where your prescriptions are falling in also. But for the most part, the $10,000 to $24,000 range is where most of your dollars were spent, there and below.
But see, that's the only way that couldn't be hitting us back, is if the majority if some of that was drugs.
Yeah.
And
Yeah,
that's
and-
also what explains why your drugs are off.
Right.
You're talking over $50,000 in drugs.
For one
Yeah,
person,
yeah,
yeah.
that's right.
And if the drugs aren't in the spec, I mean, otherwise that person would have blown up that 50,000
I mean, that could be
spec.
indicative of a person who's on a specialized
Right.
care, cancer medicine,
Right.
whatever, that, the one individual was really skewing it.
But I don't think drugs are in the spec.
It doesn't seem in this report.
I don't think it is, but I think that's probably, that may answer both of those little scenarios in with the drugs as well.
That's true, that means really your drug utilization is not bad.
It's just one person, yeah.
That may be.
Maybe.
You can't do anything about that.
Right.
Cancer drugs.
Right. And those drugs are huge. I mean, the monthly on those are just, I mean, I'm just talking off the top of my head. I don't know if there's anybody that has that, but just, there's some injectables that could be $2,500 to $5,000 a month. That would be billed as medical.
Yeah, that generally falls under medical. Now, they are prescribing pills now for chemotherapy that do fall under the pharmacy. They're very expensive though. But I don't think you have anybody out there in that category under the cancer drugs. Any additional questions on that page? Our next page is your high-cost claimants. There were two. The percent of high-cost claimants to the percent of per member per paid on the high-cost claimants. Again, well below the UMR's normative data. Your high-cost claimant paid on average per member per month was $61.27. Those that were not a high-cost claimant, they incurred on an average $214.50, which is slightly higher than the UMR normative. But again, as we've talked throughout this report, these are probably based on your prescriptions members. You have two high-cost claimants during this time period.
There's that 100,000 on 34, right there.
Yeah,
43,000.
prescriptions. Now but it says the current medical amount was $56,000, but that is not what was paid out.
No, the 100,000 on 34 is what shows up.
Right.
Paid before that.
Exactly. And then your second claimant had $39,000, and that was that $39,000 is your one inpatient stay you had.
But again, that's showing 56, so, but it's still under consent.
It's not 65.
60.
Okay, so your spec is 60, so that's why this is a spec claim, a specific deductible claim. Okay, so it used to be 50,000, you raised it to 60, so it's just scooting under. But it is just medical, because otherwise it would have blown your spec with the drugs.
Then page 10, your last page of this report, talks about your major diagnostic categories. So these are your top areas of what the conditions are on average of your group. You got your digestive is your highest dollars paid for illnesses and symptoms within your population. Musculoskeletal is next, and then nervous system is your third. What I like to always see is within the top 5 is your health status. That's meaning your members are getting their routine physicals, going in and getting their services done. So whenever that category is in your top 5, you're doing a good job with your members being well educated of physicals, your mammograms, your pap smears, your PSA tests, or just overall wellness physicals. Any other questions?
When will we do this again before we start talking about bidding out 2015 plan? This summer?
Generally, I like to do this, we could pull a 6-month report, which could be available mid-July. We could come back and present this again, and I will make sure that I have more of the pharmacy information with me, breaking down what your top pharmacy drugs are, mail order versus retail, or what categories those drugs fall in. So I could give you your 6 months worth of data mid-July.
The other thing we're going to do, Judge, that we've talked about a little bit, so I'll probably be thinking about it again, is there's 2 other items that at the same time they're going out to bid, they're going to know from us if we're going to be changing the plan as far as deductibles, as far as maybe changes on the co-pays. The other thing we've talked about is putting in some
Retirees.
Those things need to be determined, and we need to have a plan in place. Maybe we don't start on January 1st or 15th, that's when our plan is. But those, they're going to need all that information. Because it affects all the bidding.
Yeah, we we've done a lot of talking, but we hadn't taken any action. We need to take some action this year.
And you're also still within your pricing guarantee for 2015.
What does that mean?
That UMR offered when you selected to come with us, a multi-year guarantee on the rates. So for 2015.
You talking about the rates y'all charge?
Yes, so our administration fees. So you have a guarantee actually through 2015. There's a slight increase for next year. That when you accepted our proposal, it was 13, and then 14 was no increase, and then there's a slight increase for 2015, but not in every category, but most. But you do have a contract with us through 2015, and I can
For
share this.
administration.
For administration.
Not for the stop loss.
Not, yeah. The stop loss renews every year. And we can always take that to market and look at, the best rates available for the best offers out there.
What do you have available? And I'm pretty sure it's available, but I don't know that we've ever discussed it. Apps for your phones and tablets to keep track of your medical
We discussed
expenses and
that in
such.
enrollment meetings.
You did?
Yes.
We rolled out an app last year. I have a flyer on it. Actually, when your members go out to our website, there's actually information about it. There's a picture and it reminds them that there's an app. We are actually redesigning our website. It rolls out in a couple of weeks. There's a training session on it that Christy's been invited to, but we are redesigning our website to make it much more easier for members to use. Right now, there's multiple steps that they take once they to log in, and then once they're in there, I found it cumbersome as to where I go and what I look at as a member. So we redesigned that, and we've had an announcement on our page for probably 4 months.
And when is that happening?
April 18th is the official day that the new website goes live.
So maybe we can talk about that midsummer as well, when we're talking about some of these other things.
But we do have an app, and we did talk about that, because that got rolled out last year. We did talk about that during the open enrollment meeting.
There are so many people, though, that have never even gone on to the computer and done a user password for just doing it on a computer.
The other information that this is kind of bringing out today is the money that's in the insurance fund. At the start of this fiscal year, it was $652,000. As of today, it's $552,000. So we have used up $100,000. Premiums are going in there, the part of the county's contributes going in there monthly every time payroll's done. And claims are coming out every time claims come through. But so far through March 31st, we've spent $100,000 more than we brought in, but we still have $552,000 in the insurance fund.
Is that the norm? I mean, over previous years?
Well, no, those years, we didn't budget to put in the additional. We usually budget to put additional money in there, $125,000. We didn't do that this year because when we finished the year,
You had more than you normally do.
like you said, there's over years that it's going to be down here, every year's going to be up here, so you can't. I wouldn't recommend.
Thinking that that's going to be the way, yeah.
We're going to need to fund some extra money here at some point.
Well, our budget has benefited, the painful things in our budget have been counteracted by the good things here, and we can't get used to these kind of numbers. I'd love to say that this is going to be the future, but we know that that's not going to be the case. We still need to start looking at some ways to tweak our plan every year to find the leaks and find ways. I went to that Health First seminar that they have every year. Gosh, they did a good job. And I'm not bragging on Health First, but I learned a lot. The people that they brought in to speak and talking about different ways that they're manipulating plans to encourage and to punish was really good. And, monitoring people that aren't going to and doing their annual checkups, that aren't taking their diabetes medicine. In other words, they're monitoring that so
Yeah,
closely.
we can pull claims to see who exactly went to have preventative. And you can design your plan to be a monetarily incentive for those that do what they're supposed to do. I've got another self-funded group in Paris that is moving to that this year. They are checking, they actually had a promotion where if everyone went and got their preventive thing done, and they actually had, are you going to have a health assessment on that, on your new website, where an individual can go in and take like a health assessment of their personal health? Okay. That's what this other group was doing, as making it a mandatory
Making it
thing.
mandatory, or
This
you pay
is-
more.
Yeah, they gave them 3 months to go online, and a lot of those people had, like y'all, never gone in and done a user password on the website, but they said you have to do that. Then you have to go and take this health assessment. That's a mandatory thing. If you don't do it, then next year you will pay more, okay? Then they also incentivize them to go and have their preventive annual exam done, because even though your numbers are really good, you probably have some people that aren't going to get it, or some spouses that are not going to get it. You know, men are notorious for not going and getting something done unless they're sick. I'm married to one. Anyway, so they've incentivized them also to go and have that preventive test done, and then the administrator can pull and see exactly who did go and get that preventive visit done. You know, where we told them, don't say anything's wrong with you, just go and say you're here for your well visit. And they actually did a further incentive internally, where everybody that did do it in the first quarter, their name went into a pot and gave away a free Kindle. Okay, which is you know, a pretty nice prize, just to go and have a doctor's visit that's not going to cost you anything. You know, so
Well, that's the kind of stuff I'm talking about.
Exactly.
Because this is the biggest item on our plate. And it's time to start doing some of these innovative ideas that are going to rub some people the wrong way, but nonetheless, if we're going to continue to provide this level
Right.
of quality, and this is a high-quality plan.
And the gist of the matter is, your employees pay very little for this wonderful plan. And unless they start, I guess, being a more proactive, being an active participant in it, and making sure that they're doing everything they can to stay as healthy as they can, you know, make that premium adjust for those that don't follow.
We're hesitant to want to raise any deductibles. We're hesitant to want to raise any dependent care costs. There's got to be a trade-off here.
Right,
And everybody else is doing it.
yes.
We got to get on, and I think that there's some things that if people will comply to the new set of rules, we could continue to provide pretty close to what we're providing right now.
Well, even your hospital has set up a program for smoking cessation, for BMI testing. I mean, and that's pretty intensive. What I'm not suggesting that you maybe go there the first step, because it's kind of almost like step therapy with your plan design. But the other group in Paris that I represent, they didn't go that far. They just said, okay, we just want you to go take your health assessment. Right. See if you have a tendency to be diabetic. You know, I mean, because I think a lot of people might be borderline and they don't realize it. Or maybe have a problem with high blood pressure and they're not getting treatment. Those things treated early can nip a lot of your bigger claims in the bud.
Yeah.
Is
And even if we don't put them into effect this year, let's start giving them a year's warning. Hey,
Exactly.
while you're here, let me tell you what's coming online a year from now,
And
so you can be prepared.
that's what the group in Paris did. They started this year and said, okay, we want everybody to take a health assessment, and then we're going to, what did they do, Brady? They did a drawing. They did it every quarter. They pull the preventive visits every quarter, and those people's names went into a drawing for a Kindle every quarter. Okay. Do what again? Oh, it was at $500? That's what it was. They were giving them, and you may not want to do that, but this was an independent, you know, yeah, you can't do that. You can't do that. But what I'm saying is,
Hey, for what it would save you in the long run, that's pennies.
Sounds good.
well, you might give them a day off. You know, I mean, you might give them some free hours off.
Gentlemen in the back.
Judge, one of the things that you're going to have to do is training for the employees, get them in here for an hour and tell them what you're thinking about doing and why you're doing it. Because I wasn't aware really that when Dr. Merriweather gave me that generic, and then he give me a brand name, I didn't realize how much more it's gonna cost the county. I realize it's gonna cost me $25 more, but if we can do some more
Right.
training with employees, I
Right.
think we get that to them.
It might make it would make a difference. Okay. All right.
But these things just need to be discussed and then implemented in a normal, thoughtful way, so that you're not spurring them into it, but giving them, say, okay, we're gonna do this first, then you've got the opportunity to make these adjustments. If you don't, then
Yeah.
things change.
And I think we have the right to do that, as long as we're providing a plan that's in the top echelon of quality plans in our area. There's got to be some give. And it's all for their own good anyway. It's not like we're punishing them, we're helping them out, maybe
Right.
bringing to light things they don't know about. Sure.
Is there anything wrong with like getting employees, that smoke, that choose not to live healthy at all? Possibly increase the rates on those kind of people, or is that?
Not in my opinion.
You can have
I know what they're talking about.
a lot of my clients are doing that. They're doing a smoker and non-smoker premium charge.
I'd like to start that this year.
Most companies do that.
Yeah, the hospital, definitely. What I was just writing her a note about is that one of the things that, again, this other company has done in the past is they provided a health fair where you could do it here or maybe at the convention center. And in their case, their carrier actually, they contracted with these outside vendors that actually came and set up. Kind of like you've got the thing, you've had the things in the mail about the lifestyle thing where they do all those tests. But this wouldn't be that extensive. It would be checking blood pressure, doing just a simple finger prick to check for your sugar, see if it's elevated, seeing if, BMI, for those folks that, might need to lose a little weight. Just some simple level tests, maybe incentivize your folks to go and utilize that and just say, hey, and then what happens is these folks actually got a report back, an individualized report, and said, did you know that if you would lose 10 pounds or whatever percentage maybe, that your risk of diabetes goes down, your risk of heart disease goes down, all this stuff, your life expectancy goes up. Is that something that is available through UMR or?
Let me check and see what we've got.
Okay.
And I believe the health assessment is something that's available out there for members to complete.
On the website.
And that, again, gives them the overall, at the end, it gives them the results of, it's, here's your weight, and in that weight, based on your height and your bone structure, your BMI is X. And then it does go on to say that if you were to lose 10% of your body weight, that you would be in this category. It would say pre-diabetes is the best thing to catch early. Because if you can get someone to change their lifestyle of eating and losing weight and not becoming a diabetic, because once you're a diabetic, you can't reverse that.
The group in Paris has about 300 folks. When they did it was a company called Catapult actually did the program. So, which y'all could contract with Catapult. But anyway, the Catapult people came in, they set up, they only had 40 people attend. But out of those 40, 22 were diagnosed with pre-diabetes.
I didn't even know it.
They didn't even know it and had never, and the majority of those folks had not gone and had a preventive or well visit in years. But since it was offered to them on their job site, they took it and it was free. And I think they even gave them, everybody that participated, they gave them like a half a day off or something to use at a different time. They incentivized it a little bit so that they came. But even if only had 40 people show up, which, is not really good, but sometimes that's the case. It's hard to get people to go do things that are
Word spreads,
Well, I know we've got several that go to the gym, so that could be, could we use that somehow?
We can give them a happy meal for profit.
Well, is that a local gym that might want to partner with the county and offer a discount for
There's some
employees?
there's some of them use the local gym, some of them go to the health.
the wellness center.
The wellness
And then
center.
even CAPS for our employees, Steve subsidizes, how much does he cut? $10 a month for the cost of the gym membership at the wellness center. here in Mount Pleasant for those folks that want to make that available. Whether or not that would be something, that's just something that he's trying to do to kind of get folks moving a little bit more.
Let me ask you a question on the deal with the smokers. How do you monitor that?
Is that just is it a
They
word?
sign up and say, yes, we are a smoker, or if they say, if they have.
I can tell you, I can do it.
Well, there's some groups.
You're not gonna be able to look at that.
No, Health First required them to come in at intervals. If they agreed that they were going to get that lower premium, they had to prove it.
Yeah, they had to,
So
some
that
groups
means
have gone
that means
to
everybody that said I'm not a smoker, they check you.
Well, no, the ones that said I am a smoker, and they were giving them help with smoking cessation somewhere in there to achieve those lower rates. But if they achieved a no smoker classification, they had to back that up. I can't remember if it was two 90-day checks or something like
You
that.
can do swabs, you can do
did that?
blood work. Swabs
What
are
if they,
easy.
what if they're smoking?
At the Health First seminar I went to, they were talking about ways to incentivize employees to get them, you have different tiers of premium. If I was not doing what I was supposed to, I might have to keep in our plan and pay
You don't go to
25%.
visit, you get charged a higher rate.
Super.
Yeah, you don't go get tested, you're charged. How much does the testing cost? We have no idea.
I can tell you which one my employees smoke.
But you're not gonna know how they fill that form out.
Well, that's true.
What I was-
I got to take it off.
What I was saying is that if you're gonna mandate something like that, you'd almost have to have, everybody would have to go and have an exam. Otherwise, they get charged a higher rate, Because otherwise, like Carl said, all they go, but I did. Well, you didn't
See,
actually.
dipping is considered a tobacco.
Yes.
So it would be the dipping, it would be the,
Yeah, the anti-tobacco in their system.
yeah. And you got to think about those e-cigarettes. They're now the new thing that some of them have, the tobacco in that little nicotine in that liquid they
Still
use.
healthy.
Yeah, because it's got the nicotine in it.
But still, the nicotine would be caught by either blood work.
It's done through a test. I have groups that do the honor system, and then I've had groups that have done the honor system and felt like it wasn't working and is now requiring either a swab or a blood draw to verify because you could say, I don't smoke because they don't have a cigarette, but they do.
And it would have to be random.
I got some of those. I don't
Yeah.
think they tell the truth either.
You're right. Because that to them is not smoking.
Right.
All right, well, let's plan again a meeting for late July, early August. That'll help us with our budget process once we get that next.
Earlier the better.
I'd say
You can do it
mid-July.
by July 15th or something.
I can have this report by
Earlier the better.
15th of the month.
The first 6 months,
What day is it?
I'm going,
The 20th, the earlier July you get, the better.
Well, this would be available, the 6-month report for 2014 would be available around mid-July, like 14th, 15th time. So if you give me a couple of days to pull it, put it all together.
that'd be for the period ending June 30.
Right, exactly.
Well, let's look at our,
14th is available.
You had January through June 30th?
Right, yep.
July 14th is a Monday. When is normal court date?
what about the 18th to be a Friday to have a
Does that give you enough
workshop?
time? Yeah. Can look at that. Okay, so July 18th.
9 o'clock, July 18th? 10? 10 better? 10 o'clock?
Okay. And at that time, I'll have,
Nine.
I
we'll
thought
have
you said July the
examples
10th.
of options that you might want to implement.
Anytime,
for
9
us.
o'clock's better. I like 9 o'clock.
What's better for y'all, 9 or 10?
Anytime.
9 o'clock.
9? Okay.
9 o'clock on
Midnight.
Friday, July 18th.
Whatever. What time?
9 a.m.
Midnight.
And at that time, y'all really need to have an idea what you want to do on highways, the government rules, the premiums, just premiums, just the
And I can kind of pull some reports that show how many folks have met their deductibles so far. We could look at how many met
You got some similar plans that you could tell me what their premiums and deductibles are?
Sure. Yeah, I can tell it's, oh, they're not even in the ballpark. Or deductible or premium. And you want it to only be self-funded or just regular size groups?
Well, you can give us, you can, as long as you designate, as long as you identify
Yeah.
self-funded, it's got to be pretty much the same size.
Right. Yeah.
What were you gonna say? No, I just saying. Okay, gosh, I wish we could have this kind of report all the time. This is great.
There's, you know, our reporting system, you have access to that whenever you want to. That has almost 26 different reports available. It's called InfoCourt. Judge,
Brandy can run,
Right.
Christie can run. We can set this up to run monthly and just shoot it to Brian, and you can distribute it. I don't think I have everybody's email, personal email, or we can give it to Carl and he can distribute it.
okay, we can set it up under Christie's ID.
And it'll just automatically go to her. Yeah.
Here's a, like, this is for
Do any of y'all have any questions or any topics you want to continue to hear about from CAPS? Anything else you want to talk about? Okay, hey, thanks, Brandy, Tony, Chris.
Thank you, I appreciate the time. It was nice seeing everyone again.
All right, I'll move for adjournment.
So moved.
Motion by Commissioner Hockaday, second by Commissioner Hinton. All in favor, say aye.
Aye, aye.